Thank you so much, Victor, for the introduction. Good afternoon. Thank you so much for the invitation, for the organization, for this great symposium. I'm very honored to talk now. And I took a little bit the liberty to step back and not talk too much about my work, then just compose some general thoughts about how AI will be or is being used in the clinic. And so let me just fix that right. Okay. And so what I'm going to do is I looked at the approved tools, clinical AI tools that we have access to right now, and figured out some promising AI approaches that essentially emerge out of this consideration, and then also focus on this idea of background AI as a very promising approach for the future. So as a starting point, I looked at the FDA approved AI tools currently available, and there was a very nice paper that describes those from Benjamin's from last year, and that paper also provides a database, and that's a disclaimer. I think the database does not contain the recently announced tools that were released as part of the COVID pandemic and maybe preliminary release. But other than that, I think it's pretty complete. And as you can see, there are about 35 software tools right now that have actually the word AI or machine learning in the FDA approval. And here you see some infographic on those, and you can see that most of them really work in the domain of radiology, with some of them also in oncology because they detect some lesions and so forth. But radiology is definitely the main driver here. And if I looked at these tools, I started kind of trying to categorize those. And the first categorization that comes in mind are the following. And that's a terminology which is pretty common when people talk about AI tools: the assistive tools and the autonomous tools. So in the assistive tools, and that's a very important distinction, the AI presents the results to the physician, which also looks at the source data to make the interpretation. In the autonomous systems, that's kind of the holy grail. There, the AI just looks at the data. The physician is not involved. Interpretation is done completely autonomously. And so these are kind of the major distinction, and some people call this level like 5 AI, or they're called assistive systems level 1 and 2 and so forth. But overall, this is kind of the major distinction we have to make. And then the next distinction I will introduce here, and that's just words that a terminology that I propose here. I'm sure there's a better terminology, is like assistive foreground and background systems. So what I mean by that is by foreground systems are systems where the AI output is presented to the physician. In background system, the AI output is actually not presented to the physician. It's kind of magically something happens in the background. The physician can just focus on their main tasks. An example is, for example, a radiologist that has 10 radiology exams to look at, and the AI in the background changes the priority of those, changes, for example, a particular radiology report to be seen first because that patient might have a bleeding in the brain or something that needs urgent attention. So that's kind of magic happen in the background. All right, and if I look at those 35 systems in the database, and I'm dividing them up into these different categories, interestingly, only 2 or 6% are actually autonomous systems. So there's essentially no autonomous system right now. Most of them are assistive, so where the physician is involved in the AI and output and in the interpretation, and majority are foreground systems, and actually a fifth are background systems, and we'll talk about those. So let's quickly first talk on the autonomous systems that are around right now. And again, if we talk about autonomous systems, we are talking about systems where we do not need any physician input. And for that, we want the performance of these systems to be obviously greater than that of the physicians, especially if the decision is critical. And so these autonomous systems potentially need superhuman or on par performance or equal performance to physicians. And as you know, there have been a lot of publication in just the last couple of years on superhuman performance in AI. It started all in 2017 with the wonderful paper by the Troons group from Stanford showing that AI and convolutional networks can outperform dermatologists. And following that in rapid succession, this is just a selection. There have been other superhuman performance papers, either in lung cancer screening, breast cancer screening, and then just last year and prostate cancer screening and so forth. So overall, these systems might be able to perform autonomously, but if you look around, as you see in the FDA approval at least, there are few real-world implementations, and the reasons are manifold why this is the case. Clearly, the real-world setting and moving one system trained in one hospital to another is just a very fundamental, difficult proposition. I think we're still lacking kind of some of the safety considerations for those, and also some legal considerations about responsibilities. And clearly, these studies are just a few years old. It might just take time for them to really arrive. But if you look at the two systems that are actually approved, and the first one that claims that they have been ever approved, the first ever approved autonomous AI system is this IDX-DR system. And some of you might know those. And so these are for diagnosing diabetic retinopathy, that the patient just has to kind of access this device, and device makes a diagnosis. What's quite interesting is that the sensitivity is actually not that good. I mean, it's good, but it's not perfect. So it would miss 13% of the cases. So why did the FDA approve such a system? And it turns out that it's actually a low risk setting. In diabetic retinopathy, it's a chronic, slow-moving disease. Early detection is important. So you're happy that you catch a couple of patients, but patients that you miss or that you misclassify, because these are chronic patients anyway, that they're diabetic patients, they will be followed up in a couple of months, in a year by their physician. So nothing is lost really, and it's more gained than lost. And so what I, at least, my impression here is that the first movers in autonomous AI will be those low-risk AI tools for chronic conditions with and they can have below perfect performance numbers. So we'll see a couple of those in the next years, I suppose, like for example, in scleroderma or other types of chronic diseases. But the future is bright. And I think autonomous AI will emerge, especially in domains with highly standardized workflows like pathology, radiology, microbiology, or dermatology, and obviously also where there's a lot of available training data. So that will be very interesting how they will be introduced in the clinic. Clearly, they will free up time for specialists. They will take on the regular workload. And obviously, there are a lot of interesting consequences with that. So let's go now to the majority of systems that are currently available. These are the assistive systems. And let's start with these foreground systems, which I call foreground. And so these are systems where the physicians consumes the AI output for making the interpretation. And there are two main types that I find. One is those annotative types and the ones that do decision support. The annotation type systems, they present the physician with an augmented reality kind of, or at least augmented data. For example, in this IcoBrain system, it would indicate lesions in the brain after stroke. It would also measure these lesions automatically. So it takes on a lot of interesting tasks. In the decision support systems like OsteoDetect, it actually shows or overlays the region of over here, a wrist fracture, and actually makes also recommendation about the diagnosis. But again, these systems do not work autonomously. In the FDA approval, they clearly say you still have to look at the physician has to be involved, has to make the final decision. So when it comes to evaluation, these systems are the evaluation is done essentially where you measure the performance of the AI on the physicians versus just the physician itself. And what you want to see is that the combined interpretation actually is better than that of the physician. And in case of the OsteoDetect, as you can see, the unaided, so just the physician has an AUC of 8.84 and a 4% increase if you use that tool. Not that good, but again, it's an FDA approved tool. If ever, I'm just mentioning that quickly, we're going into the molecular tumor board with such an AI system. We will do exactly the same thing. So that's actually a planned study that I'm involved in. It's called Encore Navigator. It has access to real-world cancer data and sequencing data and AI. And so the idea is to do a clinical trial. And the clinical trial will be done exactly here as in OsteoDetect. Essentially, you ask physicians to judge, to make a treatment recommendation based on standard care process data sources like guidelines or available RCT. And so that's like one arm. And the other oncologists would have access to an AI system that can also look at real-world cancer sequencing data and make a decision with that help. And so again, we would look at the difference between the two settings. Okay, so assistive tools, why are they so exciting? They're exciting, in my opinion, because they can enable non-experts to do tasks that experts can do. And a good system that I found in that review is this Caption Health Caption Guidance system, where non-experts speak nurses that are not cardiologists can obtain high quality echocardiograms, cardiographs, and that they hand over then to the cardiologist. And the way this works essentially is that there is a guidance system where the nurse holds the ultrasound device, and the system tells when the nurse is holding the device correctly and when it should take an image to be sent to the cardiologist. So that frees up enormous time to the cardiologist, who no longer has to do the examination himself or herself. And I think this type of kind of support is just amazing. Just this work we are doing, for example, how you can use Assistive AI is in predicting drug-drug interactions, very important domain. As you know, in 1997, there were about only 10% of people taking 6 or more drugs. And in 2012, we have about almost 50% of patients taking a lot of drugs. So figuring out what actually interacts with each other is quite complex. And we're using AI here to detect kind of unforeseen side effects. And it's kind of impressive what you can do. And AI obviously can consume a lot of different knowledge on drugs, for example, drug similarities in terms of their structure, but also some other types of information. And I think that type of assistive help will be extremely important in the future. But one of the most important tasks, how AI can really help in the clinic in an assistive manner, is documentation. Documentation, most probably, is, I've been a doctor for 3 years. I'm not a doctor anymore, but documenting, writing reports, writing everything down, that's really takes a lot of time and takes out a lot of the joy of being a physician. So if AI can take over some of this annotation task, I think much is gained. And we already looked at the IcoBrain system, where you can automatically find contours and measure things in the brain. But obviously, where things get really interesting is like ambient documentation, where you, for example, have a Amazon Echo or a similar device that records a patient-physician interaction and automatically documents the patient history and other type of matters. So that's where things get really, really interesting. And another domain which is very similar is like writing clinical reports. Think about that. A radiologist here in the University Hospital of Zurich has to do at least 10,000, up to 10,000 thorax X-rays if you're in the planner field. And so it wouldn't be nice if you have a KI that can write a report automatically for review by the radiologist. Wouldn't that be great? And so that's exactly what we're working on, which is published in that. And we're using kind of a language model. So it's like a two-step system where we use a visual language model that takes the radiology report, outputs kind of tokens, high-level tokens about negative and positive findings. And these tokens are then used by a second language model to write a proper report to be reviewed by the physician. And that works really great. We're using kind of existing visual networks and natural language networks called ResNet and BART. And our results here in Blue Square are actually really top-notch. And we hope that such a system indeed can be helpful for a physician. I'm not talking too much about genetics, but clearly we can also bring in genetic information. We can do pharmacogenomics alerts, for example. So if patients have whole genome sequencing done or some other type of sequencing, we can look for mutations in cytochromes and other genes and alerts, issues alert that, for example, this particular drug should not be given at that moment because this patient is a slow metabolizer, for example. Again, these are all possibilities, and you can think of all different types of alerts and reminders in that space. However, we have a problem, in my opinion. Yes, we can build all these assistive AI devices. We can do it on pathology. We can run it on imaging. We can run it on genetic data. But where is this information going? Can we really bombard the physician with all these different tools? I mean, Gunnar presented something on outcome prediction in the ICU. And I guess that's just the beginning, but we can think of any numbers of tools. But where are these information going? And isn't it a problem that we at one point might end up in a situation we have what is called typically alert fatigue, where the physician doesn't want to hear about these assistive helps anymore. So alert fatigue is a real problem. And I give you just one example here, which I find an interesting one. This is a study from 2012, a very simple system that presented the physician with, if the physician saw a patient, it presented him with an alert saying, well, you know what? There's a clinical study where your particular patient would fit really nicely. Why don't you refer it to a study nurse? And that's all that the alert was doing. It would pop up if there was a match between a clinical trial and a particular patient. Now, the physicians at the beginning, you see that here in that graph, in the first few weeks, they were super happy about that and would refer the patient to the study nurse at 30% times. As the weeks go by, the enthusiasm for the system just waned. And at one point, no one just didn't pay attention anymore. And my fear is that all these cool AI gadgets we're building will actually have the same kind of outcome. I mean, we will kind of start ignoring them. So what to do? That's where, in my opinion, background systems are extremely helpful and could essentially solve much of the problems. And in background systems, you do no longer present the AI output directly to the physician, but actually you do some matching in the background. And as I said before, a fifth of the approved systems are actually background systems, which is kind of surprising to me. And background systems do not interfere with the regular workflow. It's in the background, and essentially give you some examples of those. So one is it's called Critical Care Suite. That does assessment of pneumothorax. And then if you see a pneumothorax, which is kind of a serious condition, it would up prioritize essentially the radiological exam to be seen sooner by the radiologist. Same for another system that does the same for CT scans and acute intracranial hemorrhage. And contact CT or contact CT is an interesting one where a stroke is detected. And this system actually does not do periodization, but actually calls automatically a specialist, a neuroradiologist, that can actually resolve the stroke, maybe interventionally. So there's no time delay between the patient sitting in the CT and the neuroradiologist does do the intervention. So the time will just be shrunk to a minimum. So that's very interesting. So these are all this kind of background system. And I think they have quite a bit of a future. And I think they might overcome this problem of alert fatigue. So I want to end this talk with a vision. But before I start with the vision, I'll just show you that system that we built in West Haven at the Veteran Administration Hospital. So just to give you a quick background. So this is an interesting setting where we have veterans. So these are multimorbid, typically very sick patients, and they smoke. They're not doing that well. And so there are a lot of lung cancer problems in this population. And what they found out in 2003 is that the waiting time between a first radiological report of a lung cancer, so when you see actually a lesion in an X-ray, it takes up to 76 days till the actual diagnosis is made. So these patients are just not followed up. So for some reason, they're not followed up, or these patients just disappear and it's hard to track them down. So what they did is they added this idea of a cancer alert. So essentially, somehow, when there was a first suspicion of a lung cancer lesion, there's an alert done, then the alert is given to a cancer care coordinator who calls that person to come in. And so that reduced actually the days till the decision was made, the diagnosis was made, to 53 days. So considerable amount of days which were saved. And I'm focusing on this cancer alert. So how this works is that the radiologist actually has to trigger that alert. So the radiologist sees the lesion, triggers the alert, and then the whole pipeline is running. The cancer care coordinator calls the patient that he has to follow up for a second visit, and so forth. However, we're human, and the radiologist misses the trigger. And so what essentially the group built is a background AI NLP tool that reads the NLP report of the radiologist. And if the report says, well, there's a suspected lesion, the AI tool would automatically notify the cancer care director, so that it wouldn't rely necessarily only on the radiologist to do so. And there was a study done, and again, the sensitivity and specificity of the tool was not perfect, but the combination of the two, the radiologist and the background AI, had just a much better sensitivity. So it's an extra safety net, even though the AI is not perfect. And I think that's really an interesting use of AI. And in 2017, I built an additional alert into the system, this time based on NLP on the pathology report. And these were patients undergoing routine colonoscopy. And the idea was that some of these patients wouldn't be, sometimes if you have an adenoma or some suspicious lesion, you would have to do a follow-up after 6 months, but these patients, again, would just disappear. And so how can we, again, tell the cancer care coordinator to kind of follow up on these systems, so you can automatically send the alert to this cancer care coordinators. So here is the vision. And interesting, Victor talked about it before, so I'm just summing it up here together. So essentially what you have is you have AI working in the background, doing stuff like finding out whether there has to be a follow-up planned. And again, the AI won't be perfect. There will be false positive alarms, but it won't matter because there will be case coordinators who screen for those, and the doctor only sees the really relevant information. But you can add any type of service here. You can have an AI machine running on the images, finding suspicious lesions. You can have an AI machine working on the whole genome sequence and finding mutations in the cytochrome genes and telling, for example, the physician that he should potentially change a medication to some other medication. And all of that could run in the background. We most probably need some sort of a layer between the physician and the output because of all these kind of false positive alerts. And so, yeah, so I think that type of vision would be something we could potentially do at the university hospital. And we heard from Victor before that something like this is already being done in some other institution where if a digital pathology analysis showed that there's a lesion, but there was a negative report by the pathologist, that the same slide would be run again in the same pipeline. So this is kind of has a similar flavor, but I think that's really where we should be going. So these are the background AI and the big promises here. All right, so that's all I wanted to say. According to this database, there are about 35 approved AI systems, very few autonomous systems, and those only in low-risk chronic disease screening settings. So we're still waiting for the high-risk autonomous systems arriving in pathology, radiology, and other regions. I think assistive AI systems are the one, obviously, where we have dominating in terms of commercial offerings. Personally, I think they're highly promising for supporting documentation tasks. I think if we succeed, that we can take the documentation tasks off physicians, we can really trigger a renaissance of the kind of physician experience. And also, it's quite interesting, we can enable non-experts in performing advanced tasks. And so that's really promising. And as I mentioned before, background AI systems are key for frictionless introduction of AI in the care workflow. You don't bother the physician, and I think it really will help in helping elevate the quality of the care. So with that, I'm ending my talk here, and I'm opening for questions, and I'm also looking forward to the panel discussion. Thank you so much.
Thank you, Michael, for this really excellent talk. I was very excited about the high-level overview, because I think this is something that is so important in the way that we develop these algorithms and in the way that we bring them to the clinic. Maybe if I may directly start with the first question. I'm looking at this from a very practice-oriented perspective. I'm leading this digitalization process at the hospital, so I get bombarded by different companies that have great solutions, and I come back always to the same point. Every company or every provider at the moment has their own framework where they can apply their own software solution, but it's very difficult to actually make these interoperable. So do you see in the future landscape, do you see a need for a unified framework where basically all of these AI apps would run on the same backbone to prevent that in the end we have a completely fragmented software landscape in a hospital with lots of providers, each of them giving us an individual app with individual performance points and hardware requirements?
Yeah, so I don't have any detailed answer here because I'm involved in so many architecture discussions here at the hospital. I think you're absolutely right. We cannot afford, again, given all the promises of predictive AI, right? We cannot afford that for every question we install our own hardware infrastructure, right? And so actually Gunnar Raj, who talked just before, we actually crafting some sort of a vision where we can have one environment, right, where data flows in, right, and where these kind of algorithms could run in a unified setting, right? That's obviously something homegrown, right? How to incorporate kind of vendor systems into that ecosystem, that's a big challenge, right? But we cannot afford multiple systems. I fully agree, and I support you in that statement. Thank you.
Thank you. Are there any other questions from the audience? We've one in the chat. So there's a question asking if you know of any German language algorithms for NLP processing of German language clinical texts at this point.
Oh, that's a very good question. Actually, no, because I just started. So far, all my work has been in English. We are just accessing our first German corpus as we speak, and at this point, I'm not aware. But I have to say we're just getting into that. But that's a very good question. I know there are German NLP companies that are quite successful, but I would say Germany is a low resource setting. There's definitely not the amount of essentially training data and other types of material for NLP purpose definitely limited in terms of when you compare it to the German, the English and Anglo-Saxon space. That's for sure.
Can I add?
Question,
sorry, maybe just adding a comment here. So I think, yeah, I fully agree. A lower resource setting. even de-identification tools are not available very much for German. So I mean, we have worked with OSZ to de-identify some want to develop a tool to de-identify texts. So this is the first step, but only when we have a de-identified text we can then use more sophisticated tools on top of it. So I think it's the first step.
There's a question for Dr. Zanetini-Lang, please.
Thank you. Michael, I was wondering, how do you see the role of IE-based decision support for patients? You talked mainly about the clinics now, but I can imagine that patients are more likely actually to use these kinds of tools.
Right. Well, I think it's a wonderful question, and I'm starting philosophing about these questions, because in the end, I mean, the ultimate consequence of what's happening here is that, okay, we are putting expert knowledge into a box, right, and making it available to non-experts, right, and eventually this knowledge will end up in the patient space, right? I mean, there's no question that as we gather our own data, as we collect, as we do our personal kind of self-assessments, kind of, that we can access medical knowledge ourselves as patients, right? So that's a space where we're going to, and so I'm fascinated by thinking about that. But in terms of AI for patients, actually we just published on a very interesting AI applications for example, just one example, right? If a patient is sick these days, the first thing the patient's doing is not going to the doctor. He's going to the doctor Google, right? And so how do you know whether a website has a high quality content or not, right? So there's a huge problem. So we built an AI engine that actually reads the health websites, right? And looks at key components about high quality health information inside the website, like references, current knowledge and other things, and makes a recommendation for the patient, right? And so you can read the paper. Is called Auto Discern if everyone is interested to look at it. But so yes, so I think patient-facing AI has a huge future, right? And I think we're just seeing the beginning of that.
I think this goes very nicely along with some of the ideas. I'm just thinking of the book titled "The Patient Will See You Now," where basically there's an empowerment of the patient versus the physician. I'd be very interested in your views on that. How the adoption of these AI applications, both on the clinical side and on the patient side, will shift the patient-doctor relationship.
Yeah, well, yeah, right. I mean, if digitalization did anything, it broke the information monopoly of the doctor, right? And I think that's with or without AI. And so once this happened, right, I think everything changed, right? And now that AI is accessible to physicians, this monopoly will shift even more. And so yeah, so that's a little bit where I'm starting to really think where the future is going, right? And I think also kind of the boundaries between care at home and physician care, right, will shift, that's for sure.
Any other questions? I see several videos, but no hands. Abdullah, please.
Hi, Michael. Thanks a lot for for giving this nice overview of AI and how it's implemented, or it can be actually implemented in the clinics in the future. And is currently already done to a certain extent. I was just wondering, I mean, we hear about these AI chips, for example, that Apple is introducing into the iPhones and so on, and there's, I think, also like some AI algorithms working in the Apple Watch, basically that recognize whether you fall down or not, and so on. So, like in this, with these gadgets, this also going to change basically how AI is, will find its way basically in the clinics. Given now that there's the whole, IT technology developing industry, basically, we're really concentrating on it. I mean, how is this going to impact the clinics and how we actually do our daily work in the clinics?
Yeah, I mean, there are many, I mean, I see many kind of facets in these questions, right? I mean, maybe I hear edge computing a little bit, right? That we're moving AI kind of really to the periphery towards the patient, right? I mean, if you just look at that aspect, I think that's, that will change things quite a bit in the sense that we can get updated information from sensors, right? From patients once they leave the hospital, right? That's just one aspect that I'm thinking of, right? So, but I'm not sure if you think about kind of the application like this, but that's just something that comes to mind, right? That these AI tools being close to the patients, they can detect multi kind of sensor streams, and they can inform us about outcomes that we had not access to so far, right? So patient-reported outcomes using these new sensor technologies will change the way we perform medicine, because we will have a much more fine-grained association between treatment and how patients really do, you know, after they leave the hospital, for example. And so if at all, I think these tools, as they enter the patient sphere, will give us a much more understanding of how well we're doing, for example, right? But maybe you meant the question a little bit differently. So, but I hope that this aspect satisfied some of your question.
No, I think it's really good. I mean, especially, you know, that exactly these gadgets are actually generating data, and it could then really help us basically, you know, when the patient leaves the clinic, you know, to survey them further. And I think for that reason, this is absolutely true. So this could be really something where these gadgets and those, you know, technology companies could really step in and help us basically to give patients better, you know, to follow up at least on the treatments that we give to patients in the hospitals. Right.
Yeah, raised hand by Gunnar, please.
Yeah, it's a follow up again. I don't want to answer questions here, but so it's a thought maybe which adds to. So I currently see quite a disconnect between what Apple and the technology companies do and what is done in the clinics, and it's not very well accepted. I think by physicians what let's say an Apple Watch measures, and I mean I see a great potential here, but I think it's going to be a long way to get acceptance by physicians to accept what an Apple Watch can predict and what cannot predict. And right now it's simply ignored and it's not trusted at all, I think. And it's a long way to get there. And maybe we have to contribute to that.
Jürgen?
I'd also like to follow up on the topic. So the thing we are using for our sequencing analysis is actually one of the modules that is very much alike what you find in smartphones and Apple Watch. That's these integrated systems on chips, which have a GPU and a couple of CPU cores. And what I see in these gadgets is that they actually promote the hardware development that we could use in medical AI. So we might not want to use an Apple Watch, for instance, or a smartphone, but we can use that same hardware for our purpose. And it's really affordable and can really be distributed at low cost everywhere. And I think that's the potential for us. So we are kind of a bystander in terms of industry, but I think it's very helpful for our purpose because we don't need clusters anymore. We don't need high performance computing centers for many applications, but we can boil it down to something that can run on a battery and that can be integrated into a monitor or into a microscope or into a sequencer.
Thank you, Jürgen. We've time for one more question, Professor Guggenberger.
I would like to respond to Gunnar when you mentioned that clinicians would not kind of pick up this technology. Maybe one could reverse it and to start a kind of a controversy at the final discussion. And maybe we are just waiting for the evidence. So we are a bit disappointed, I would say. I mean, we are used to having clinical trials, randomized evidence, hard data, not just a shiny watch which is sold in some kind of high glossy paper. So why don't we have that clinical evidence being available yet to convince us as we've been convinced from any other technology?
Yeah, I think Okay, I mean, now we go into the discussion, but I think it takes time to do that. I agree, and we need to have this evidence, and this is what I also described in my talk, that we need to go to the next step to have the clinical trial where we show and prove it makes a difference, right? So, and the same things need to be done for the Apple Watches and so on. So to show, yeah, I don't know, the heart monitoring or whatever in Apple Watch makes sense, or the SpO2 monitoring makes sense, and under which conditions. So I agree. But it's maybe not the first thing they do, because that's not what gives customers. But eventually, I think it's what we need. Yes.
I see there's already a lot of interesting questions and a lot of energy for the discussion session.